I think go ahead.
All right. Good evening to all the participants. Good evening to all the organizers. And most of all, good evening to Dr. Vivek, sir. Thank you for joining us today.
Thank
Welcome
you.
all the participants to day two of Confluence of Choice. Today, we are going to have the advocacy workshop on women, children, mental health care. With us is Dr. Vivek Madi. He's a influential obstetrician, gynecologist, and lawyer who also has a hand in hospital administration. So he's really a full package, and we are privileged to have him here with us today. Thank you for joining us, sir. Uh, I want to today we'll just give a small introduction on the World Medical Association. I'll introduce our guest today, and with that, I'll hand it over to our guest to continue the session. Okay. So World Medical Association is are one of our partners for this event, and it is an international organization which endeavors to achieve the highest standards in medical education, medical science, medical art, medical ethics, and healthcare for all people around the world. It was formed around 75 years ago in 1947, along with our country. When it had its first meeting in Paris, there was just 25 countries attending at that point of time. Now it is a conglomeration or a confederation of many national associations across the world with around 116 national associations around the world as of now. It has built formal relationships with the WHO, with United Nations AIDS, with International Labour Organization, with the International Organization for Migration, UNESCO, UNICEF, and many, many more, with alliances spanning across the globe and partnerships in every country. WMA stands at the forefront of raising medical ethics to the highest possible standards all around the world. It is our privilege to be having them as a partner for this event. Today with us is Dr. Vivek Sir. He's quite a remarkable person within the healthcare field. He stands at the intersection between medical care and legal care. The interesting story for him, which we need to know about him is Dr. Sir became an obstetrician gynecologist, and then seeing the plight of patients, seeing that different sections of patients are getting different levels of care, he got himself trained and qualified as a lawyer. And then to implement this, I think on a day-to-day level, on the ground level, he also has a huge hand in hospital administration and is qualified in that as well. There are countless stories where his intervention has led to better healthcare for many, many patients. So it is a privilege to have you with us here today, sir. So we might also maybe gain 1% from you and hopefully become better doctors in that way. Uh, Today, he will share with us a legal perspective and a healthcare perspective on many government welfare policies, Consumer Protection Act 2019, MTP Act 2021, PCPNDT Act 1994, Surrogacy Act 2021, POXO Act 2012, and many, many more. He's sharing with us today an ethical perspective in relation to women, children, and maternal health care. A consultant, a director, a steering committee member of the Bioethical Law Department, an international chair in bioethics, an author of textbooks, ex KMC Association president. It's a pleasure to have you with us today, sir. Thank you for joining us, Dr. Vivek. With
Thank
that,
you.
I would like to hand it over to Dr. Vivek, sir, to start his
Yeah,
session.
yeah. Thank you for the kind words and happy Diwali to all of you and for making yourself available for this nice workshop. I should thank you for that and your interest. I appreciate it. Today's workshop is on women, children, and mental health care. It's very important to us because they are the core of our society. And you should know that the the government has taken this very seriously to implement certain laws which are for the betterment of women, children, and mental health care. Uh, I'm unable to change my slide. Is that okay? Now, first, I would like to go to informed consent. I'd like to talk about this very landmark case on Mrs. Montgomery. She was a British woman, a pregnant lady who was short-statured and diabetic. Although she came under a high risk pregnancy and she had increased risk of macrosomia, she was not informed of the risk of shoulder dystocia and cerebral palsy. She went into labor, which was complicated by shoulder dystocia with a 12-minute delay in delivery. And the resultant fetus, infant, had hypoxia and cerebral palsy. She was very upset, obviously, and she went to the court. She claimed negligence on two grounds. Accidentally, she was not informed of the risk of shoulder dystocia, nor was she given an alternative method treatment like a cesarean section. Secondly, she said during labor, the doctor did nothing, seeing a deteriorating CTG score. You know, the CTG is a machine that monitors pregnancy outcome in labor. So, in spite of the CTG saying bad outcome, the doctor didn't do anything. She didn't take up a cesarean section and continued giving her a normal delivery. Finally, she delivered a normally a baby, a son who suffered from cerebral palsy. So she claimed that had she been given, she told about the risk of shoulder dystocia, about the risk of having a child with cerebral palsy, she would have opted for cesarean section. Then the court said, yes, what they say is no more should doctor take it take on a paternalistic view. They should not think that patients are incapable of understanding medical matters. They should realize that a patient should be told whatever she needs to be told to help her make a decision and not what the doctor thinks that they should be told. So, from what the doctor thinks, things have now gone to what the patient needs to know to make a decision. No more that a doctor does whatever he thinks is good. That concept has changed. Now we need to give information. We are like just like you have IT, we are basically information centers. Our duty is to give information to patients, and it is for the patient to decide what they want. Do they want a normal delivery or normal cesarean section? How long to wait? All that is the patient who makes the decision. We should take the decision thinking, yes, we know everything, we do the right things. That attitude should change. And that's what this important Montgomery versus Lancashire case came about in UK courts. And obviously, everything that happens to you in UK is followed in India also. So courts do. So what was prior to this Montgomery ruling was the Bolam test. Bolam's test told about what is the standard of care. If a doctor performs according to the standard of care, then he is not negligible. Now, it is we have evolved from this Bolam test, which also gives a therapeutic privilege. It also gave uh, allow the doctors to withhold information, thinking that it may scare the patient. All that has been removed. Now it is our duty to give information to our patients, all the risks, all and help them make a reasonable decision, and that is our duty. So, as young medical professionals, you all need to acquire information. That's all your duty is now. Acquire information and don't try to make decisions for your patient. Let them make the decision. I want you to all be aware that now there's an act called Consumer Protection Act. We doctors come under this code, consumer code. And what is this consumer code? It protects consumers. And who are the consumers? Patients. So doctors are liable to be taken to this court, and they can be punished in this court for any mistakes they make. This is what the latest consumer court says, that there are three types of courts. One is the district forum, where a patient can sue the doctor for up to 1 crore. So all what you will earn can be wiped out with one bad case. So that's how serious you must take your medicine. You might be a very busy doctor. You might be earning a lot of money. Finally, unfortunately make one mistake. What you earn for lifetime can be wiped out with one case. And the case can be fought in the smallest court, the district court, which is the cheapest court, where the patient doesn't have to spend any amount, nothing to file a case. Just a local where they stay, go to nearest court and file a case, and up to 1 crore they can get claim compensation. So then second is, if they fail that, then go to the higher court, that is the state court. In the state court, up to 10 crores they can claim. And if they fail, then go to national forum, the national consumer court, which any limit above 10 crores. The last case where versus Ambry hospital in Calcutta, a doctor was asked to compensate a patient for 11 crores, 11.6 crores. That's the amount they have to pay. So, we all have to take our profession very seriously. There's something called the MTP Act, which is the Enabling Act for women. It allows women to terminate pregnancy. It says that all women have a choice to have the baby or not. If they do not want to have the child, they can terminate. And it's a duty of doctor to terminate. So earlier this was only applicable for married women. Now, seeing social change, they felt, yes, there are a lot of unmarried people becoming pregnant. We can't allow them to go to quacks and endanger their lives. So this act was brought into force recently in 2021 and says up to 5 months, no questions are asked, you can terminate the pregnancy. Doesn't need anybody's permission. A woman says, I don't want this to have this baby, they can. It's the duty of a doctor to terminate. It also says the duty of confidentiality says clause has been introduced, where it's the duty of a doctor not to disclose the name of the patient to anybody. It has to be kept a secret. We need to not even write the name of the patient in the case sheet. We should give them a serial number and maintain the confidentiality. If by mistake you have disclosed privacy and confidentiality is lost, then the patient can sue you and a doctor can be put in prison for 1 year. That's how severe this law has come into place. And I told up to 5 months, but for certain people, up to 6 months, they are allowed to terminate the pregnancy. Up to 6 months. Beyond 6 months, yes, the baby has a right to live. So nobody has a right to do termination. Up till 6 months, you can terminate. That is a woman who has been raped, or a minor, or a woman with any disabilities, physical or mental, or a person who has got a divorce during the pregnancy, or during an emergency period like a COVID or a war. A woman can terminate a pregnancy up to 6 months. Or she's carrying a child with abnormality, which cannot be which cannot survive at birth, you can terminate up to 6 months. Okay. And when you're dealing with minors, there's a duty for doctors to inform the police. You see any minor girl who's pregnant, yes, you can terminate the pregnancy, but before terminating, it's a duty to inform the police. And you should inform the child welfare committee. And remember, a child can't give consent. So you should get the consent from a guardian. So these precautions are to be taken. So the third act which I want to tell you is this PCPNDT Act, that is Preconception and Prenatal Diagnostic Technique Act. Here, this is all about ultrasound. You must have heard about ultrasound machine. An ultrasound machine is used for diagnosing pregnancy and monitoring pregnancy. It is okay. But unfortunately, when it was first introduced, this ultrasound machine was used to see the sex of the baby. So people used to see the sex of the baby. And in India, people don't want to have female babies. So there was a taboo to have a third or fourth female baby. So what they used to find out when they know that it is a female baby, then they will go to a doctor and say, I don't want to have the baby and go for termination of pregnancy. So what happened was there was less females and more males. And when there is a difference between male and female, not every male will find a female to get married. And then what he will do? He'll go rape people. Rape will go up. So they say, so the government started to think very seriously. They said, no, 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 this is not right. We can't have more males and less females in this country. We need to have equal proportion so that every male will have a female to get married. So they brought this act and they said it is a duty of every doctor not to find out the sex of the fetus. So it's a prohibition of sex selection. And you should not even do procedures to have a male baby. So this is the act. And what they said is every ultrasound machine should be registered. So if they found anybody violating, they can go punish. That's the reason they brought in this clause. And you should get a consent from the patient that the sex of the fetus was not communicated to her. So was this brought very serious act, and every doctor got very frightened. And now they're all following this procedure. They're maintaining records and they're bringing awareness to the public that we are not going to tell the sex of the baby. Okay. Now there's another act called ART Act, that is Assisted Reproductive Technology Act. That is where to help infertile couples to have a baby. Those people who are not becoming pregnant can go to a doctor and ask for a child. Now, here again, people used to ask for male child. So they brought this act and say, no, 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 you can't be sex selective. You can't have for a definite baby. You can't even, no, now you have designer babies coming out. People want to have perfectly normal babies, healthy babies. All this the government says nothing to do. You can't have a child which will be very tall, will be muscular, like Arnold Schwarzenegger. All that kind of babies you can't have. So they brought this act and said, you can't play God. So you should go by natural process. Do ART process ethically. Don't uh, you know don't try to cheat your patient. Don't promise unnecessary things. So they make, and they said you should also bring insurance. Sometimes all these people used to exploit the uh, donors, the suicide donors or the surrogate mothers. They used to exploit them, not pay them after getting the child. Or if they find out the child is abnormal, they will not pay the people who have donated or taken the chance to have somebody's baby. So surrogacy means you're carrying somebody's child for 9 months. Suddenly they should find the baby is abnormal, and the people used to run away from the process. And many of these people used to be foreigners who come to India to have a child. They didn't want to have a child in their country. They think, let's come to India. There are so many poor people. They will carry our baby. Why should we spoil our health and carry a baby? There are a lot of Indians in this country who are poor. Let them, we'll pay them 1 lakh or 50,000 and they will carry our baby. So they should come and exploit our people. So the government says, yes, There's something called Surrogacy Act, and they say they should, if you want to find a woman who's going to rent of her uterus, it should be for only altruism. Altruism. That is, there should be no commercial transaction, no money involved. You should find somebody who is your relative who can be a surrogate. Foreigners will not be allowed to use Indian women for their benefit. So this was a very progressive act to protect, like how our Prime Minister says, made in India, everything like that he says. Yes, if you want to anybody to be born, this child can be only Indian. So this was a very progressive act. Now the next one was this POXO Act. I feel all of you should know this. That's why I have kept a lot of slides on this POXO. What is POXO? It is protection of children from sexual offense. In India, a lot of young children are being abused. Without their knowledge, pornography, they've been used for pornography, they've been used for sexual content now because of cyber things. A lot of unfortunately they've been sexually harassed and used for pornography and for any perverted reason. So this act is very powerful act whereby just a simple complaint, the person can be arrested and put behind. And it says any sexual child where sexual activities like inappropriate touching or indulging child in touching the private parts of the perpetrator, molestation, sodomy, exhibitionism, pornography, cybersexual acts, all have been criminalized. And they said it is today the numbers are so high. There's 53,874 cases that have been registered under POXO Act. It's so common. And they said this act is gender neutral act. Even male children are being abused. We always think yes, only females are abused. No, even male child have been abused. So this is to protect them. And any sexual abuse, like even harassment, has to be reported to the police. So who is to report? Who is the one who comes to know about all this? It is the mother or a thing of the child who brings to a doctor for examination. And now it is our duty as doctors who come across this during our pediatric care when we see young children, they are mentally upset. When we ask questions, we ask them why are they upset. They come out and they say they have been sexually abused or there's a sexual harassment taking place. They do not know what to do. They are frightened to tell their parents. They are confiding to you. And they say there could be a penetrative sexual assault. It could be aggravated. It could be somebody known to them. It could be uh, just just touching. Sexual assault can also be an offense. They said even harassment, somebody trying to tease them or telling perverted words or using a child for pornography. These are 6 sexual offenses which have been categorized as serious offenses, which are punishable in law. And how do we come into place? How do we doctors come into this act? Why am I talking to you about this? Because it gives a mandatory duty. The Act says, under Section 19 of the Act says that it is our duty as doctors when we examine our patients, our pediatric patients, and we come across the child has been sexually abused. It is our duty to inform the police. So remember, anybody who has been sexually abused or some young child anybody under 18 years comes and tells you, I want a contraceptive pill, I want to have sex with somebody. No, you should tell, you should not give the contraceptive pill. You should say that you are not allowed to have sex. Anybody under 18 cannot have sex. Even kissing is sex. Tell them even kissing is not allowed. If you're less than 18 years, don't do all these things. You're not allowed. This is crime in India. We are not abroad. We are in India. And this is punishable. And it also says once as doctors, you have come to know that somebody has been abused and you don't tell them to the police, you can be punished. So that is so, you can be imprisoned for 6 months. Somebody comes to know and say, this doctor, I came to the doctor and told them this, and the doctor didn't do anything and gave me some nice contraceptive pills. That's it, gone. The doctor is can be punished. Now, to the last few slides, I've told you about all punishments. Now, I'm a lawyer now. I'm here to help you. I'm trying to tell you things, how to avoid going to courts, how to be sensible at a young age itself to realize what not to do. First thing is how to avoid litigation is primary prevention is you prevent your patient from going and giving complaint. You develop a good relationship with your patient. Think of them as your own family member. Will your family member ever go to the court or police station and complain against you for any mistake? You fight so many times with your friends, but will your friend ever go to the police and complain? So if you treat all your patients like your friends, they will not complain. So how do you treat them? I will tell you because you have four basic ethical principles to follow. I'll tell you in the next slide. The second level of prevention is your documentation. You see nurses always writing your reports in their duty nurses report. Why are they writing? Because they're taught to write. We as doctors are not taught to write. That's a big mistake. Anything what you tell your nurse, you must write down in your case sheet. Learn to write your case sheets well because your case sheets will speak for you in the court. So your case sheet will protect you. So learn how to write good case sheet legibly and never touch any patient without getting a consent because you touch anybody without their permission, they can give you a complaint and you can be liable under a section for battery, assault. You're against their wish, you're touching them. And that's a crime. You can be punished. So without, you might be doing good by doing operation. But if she has not consented to the operation, you will be at fault. That's the first mistake. Okay. So and the third very important prevention which you all have to take is insurance. Take insurance and be good to all your colleagues because they should support you when you're in trouble. Have a good peer support system that will go through. So you follow these three levels, you'll be safe from litigation. And how do you prevent a complaint from being you know, given to a police station? You must form these four basic principles. Follow these four basic principles. That is beneficence, that's doing good to your patient. Non-beneficence, don't do anything that is harmful to your patient. Autonomy, you respect the patient's decision. Allow them to make the decision. You don't take any decision for them. Allow them, give them information. Let them take the decision. Allow them, okay? Whatever it is, they make the decision. And the last is justice. Like in the COVID period, we all did our service to our patients. Be very fair in your treatment. Just because somebody is a VIP, you don't give them good treatment. And somebody is poor, you forget that. No, be fair. Everybody is equal before you. If you have these four principles, you become good doctors. And your patients will love you. And this is very important. This is what information is about. What information you need to give to your patient. Remember, you should give information that is necessary for them to know what are the risks they will have if they pursue the treatment, what are alternative treatments they can take, and how long this treatment will take, duration, and what do you expect of the prognosis. And the last and most important thing, information which you need to tell the patient is When you have made a mistake, you should know how to tell sorry and how what went wrong. Be truthful. Truth telling is very important. Don't be frightened. If you tell the truth, any patient will forgive you. But if you try to cover up, they will go to the police, they will go to court because courts are there to protect them. And I mentioned to you about records. Yes, records are here to protect you. So make sure you write your records very clearly, legibly. Don't miss out anything and don't scratch things. Never use a whitener. Don't leave any blank spaces. Okay, draw a line whenever there is a mistake. And initial, put your initial in the end of the paper. We all have a legal duty. We as doctors should uphold the dignity and rights of our patients, to protect the vulnerable, the poor patients, to act without prejudice or willful blindness, to do justice, fairness in all situations. William Osler once said that the good physician treats the disease, the great physician treats the patient who has the disease. So you treat the patient. You know your patients. Trust them. Okay. Patient-doctor relationship is the crux to our treatment. Thank you, friends. If you have any doubts, you can clear. I'm here to clear you. Thank you.
You very much, sir, for that very informative session. There is a doubt, which is there's a question asked by Pranav Vivek in the
Yeah,
chat box.
yeah,
Uh, Sir, if we
yeah,
suspect a child of being abused by their legal guardian,
yeah.
and said guardian isn't giving consent for examination to confirm the same, what is the next step to be taken?
No, there is something called Child Welfare Committee. When you have found a child being abused by the guardian, so you must go to a third person who will give consent for the child. And that responsibility goes to a Child Welfare Committee, which is formed by the government. So you approach them. They will take custody of the child. They will protect the child. End of the day is the child has to be protected. If the guardian is not protecting the child, you need to have a third person to protect the child. And the third person is somebody who is appointed by the government, and that is a child welfare committee. There's a child welfare committee. I think just Google it, you'll get there. Every city has a child welfare committee.
Okay, sir. Thank you.
Yeah.
Uh, Pranav, is your doubt answered, or do you want to ask a follow-up question?
No, sir. Thank you for clearing my doubt.
Yeah.
Sir, I had a doubt, a question
Mm.
from my side.
Mm.
Um, yeah, two questions. One is a fact question.
Yeah.
Why the 6 months limit for abortion? Why is that taken as the boundary?
Yeah. Because beyond that, there's a risk. Okay. And it also, because the risk to the mother, bigger the fetus, the risk is that. More important is the viability period. We say that the fetus becomes viable 24 weeks onwards. Any fetus born, the NICU, neonatal intensive care unit, can
Mm,
somehow make them survive. If it's less than 24 weeks, there's lot of risk. There can be blindness can take place, jaundice, lot of lung immaturity takes place. It's very difficult to make a child less than 6 months survive outside the uterus. So any child born after 6 months, neonatal care is so good around the world that you can make them survive. So that's called the period of viability. And the government gets the duty of the government to protect the child. So their neonatal government neonatal centers are allowed to protect any child born after 6 months, any baby, any fetus born. Below 6 months, it's a duty of it's the choice of the mother to terminate or not to have the baby. So they can terminate. They don't want. They don't have to tell whatever reasons are. Less than five, no. no reasons asked. Between 5th to 6th, you have to give a reason. The 6 categories of women, either you should be mentally retarded, you should say that you are mentally retarded, or you're having physical abnormalities that you can't look after, or you're divorced or something. Something that's happened, you can't look after this child. You have to give a reason.
Okay, sir.
Yeah.
All right. Thank you, sir. There's one more question from Samir Khan. If a female child less than 18 years of is married and is presented to a physician for general checkup,
Yeah.
what is the physician's role at that stage? Should he or she inform the police? Also, on the same line, should a contraceptive be provided if the female is less than 18 years old and demands for it?
Yeah, see, this is a girl who's a minor. A minor by law cannot have sex. So a minor, so if she's had sex, that it's called rape. She's not given consent. So anything without consent is called rape. So rape is a crime. So remember, anybody less than 18 years has a sexual contact. Babies there because goes on to have a baby or not is secondary. Shouldn't even have sex. So anybody who's had sexual contact, has done a crime, and our duty to inform the police whenever you're aware of a crime. It is a duty of every individual. When you know some crime has taken place, you can't keep quiet. You're supposed to inform the police. You see a terrorist going with a gun, it's our duty to go and inform the police. The same way, if somebody has raped a minor, it is our duty to inform the police. What the police does is secondary. First is inform the police. So it is not our duty to give them contraceptive advice. You can't give contraceptive. You can't allow anybody to do a crime.
Yes, sir.
So somebody tells you, I want to rob the bank, and you give advice to the person to go rob the bank. Then tomorrow you will also, if they rob or not, you will be sent to the prison for giving somebody that idea. You might have told for fun, but even that is wrong. You can't give ideas to do crime.
Okay, sir. Samir, is your question answered, or do you have any follow-up questions? You can reply in the chat box, or
shall we go to the 4 questions
Yes, sir.
are given? So let's go. Let's talk about that. I rather ask the participants.
Yeah. So I hope the case presenters are ready. Sir, please allow me to share my screen.
There's 20 minutes. No. So
yeah. So can you please stop sharing the screen?
Yeah, I'll stop.
Okay, is my screen visible?
Yes, it's visible, Chaitanya.
Yeah, so the first presentation will be of case 1 by Asta and Karvi. Please go ahead.
So good evening, everyone. Our case is on contraception counseling of adolescents. So what advice Dr. Hanuman should give to Bharti? So Dr. Hanuman should advise Bharti and her fiance Vaikunth to abstain from sexual intercourse until Bharti turns 18, for the reason that Section 3 read with Section 5 and read with Section 4 of the POCSO Act 2012 that criminalizes sexual intercourse under the age of 18. He should advise Vaikunth that he can land up in jail for at least 20 years or even life imprisonment with fine under Section 4 subsection 2 of the POCSO Act as Bharti is below 18. Further, Dr. Hanuman should also advise them to abstain from anything which may fall within the definition of sexual assault, within the meaning of Section 7 of the POCSO Act, or within the meaning of sexual harassment under Section 11 of the POCSO Act. Since Bharti is below 18 and she's a child, so any sexual intercourse or sexual harassment, even by consent by Vaikunth, can lead him ending up in jail, just in case Bharti's parents lodge an FIR. Next question.
Can
Yeah,
Dr. Hanuman counsel Vakunt on protected intercourse with Bharti? Dr. Hanuman can counsel Vakunt since he is legally an adult. So he can counsel him on protected intercourse as a part of imparting sex education. But he needs to express it very clearly that he should not have sexual intercourse with Bharti or any woman less than 18 years of age. So he can give Vakunt advice on a general basis, but to be on a safer side, he should abstain from providing him with any means of contraception, because if there is any legal case against him on having sexual intercourse with a minor, the doctor can also be roped in under the charges of facilitating the crime under section 16 and 17 of the POCSO Act.
What is Dr. Hanuman's ethical responsibility to preserve Bharti's confidentiality? So, Dr. Hanuman is bound by Regulation 2.2 of the Indian Medical Council, Regulations 2002, that says to preserve the confidentiality of both Bharti and Vaikunt. He cannot divulge even a jot of information about either their domestic or individual life to anyone unless the state laws require such disclosure, and there are no state laws in our Indian state. In addition, it is also to be noted that the patient was specifically asking the doctor not to divulge the information. So that makes it even more clear that the confidentiality satisfies the requirement of confidential nature of the information under Regulation 2.2. It is also to be noted that Bharti has also asked Dr. Hanuman to not divulge the information, and the Dr. Hanuman also stands by the Hippocratic Oath, which includes a statement that he shall respect the privacy of his parents of their patients, for their problems are not disclosed to him or the world that may know. Next question.
How should Dr. Hanuman handle the conflict of interest with regard to preserving Bharti's autonomy and providing information to Bharti's parents? So the doctor should maintain the confidentiality of information provided by Bharti according to section 2.2 of IMC 2012 and the moral bounding by the Hippocratic Oath, and should not disclose it to her parents as that may impact her even more negatively. But since she is a minor who is about to commit a crime, he may register a medico-legal case and inform the concerned legal services, child welfare center, or the one-stop crisis centers available across India, as that will come under privileged communication that makes an exception to the confidentiality clause.
Dr. Vivek, please give
Yeah.
your feedback.
Yeah, it's all what you have mentioned is correct, because it's important that we do not, we can give sex education to adolescents, but not contraceptive advice. Because if you're giving contraceptive advice, you are allowing yourself to be party to the crime. It's important adolescent sex education is allowed, but not contraceptive advice. Any contraceptive, even just your own prescription, you can be held responsible for helping them in this criminal act. So that's the basic of this case one. To inform you, yes, as doctors, don't even fall into this trap. Somebody asking you for contraceptive. Once you know somebody is less than 18 years, that's why you need to know the age of the patient. Ask for their Aadhaar card. If you're not too sure, if she doesn't look like an 18-year-old girl, ask for proof of age. Your Aadhaar card, confirm, and then you can go ahead with your advice to patient. Yeah.
Moving on to the next case. Manas and Samir, are you all ready? Please go ahead.
Yes. So, case number 2, a young bride requests secret access to contraception. What is Dr. Gunshekhar's primary ethical responsibility in this case? So in this case, Dr. Gunshekhar's primary ethical responsibility, in accordance with the POCSO Act, as she is just 16 years old, is to safeguard the well-being of Eve, who is a minor, and disclosing any information about her request without her consent will be violating her right under the Act. Question number 2. What social and medical conditions should Dr. Gunshekar discuss with Eve during the consultation? So, given that uh, he should discuss that she is malnourished, first of all, and the potential impact carrying out a pregnancy could have on her health right now. And the discussion should be age appropriate and sensitive to her well-being, in that she is able to understand also like any medical concerns she has. Also, she has an underdeveloped pelvis, so Dr. Gunshekhan should explain to her that she is not fit for childbirth and it can potentially risk her life. And lastly,
Question number 3, I
should
would
doc-
like to answer.
all right.
Okay, so about question number 3, the question says that should Dr. Gunasekharan inform Eve's husband about Eve's request without her approval? So the answer would be no, because in this case, patient's autonomy is very important to be maintained. So the maintaining patient's confidentiality and privacy is important. Respecting the patient's autonomy and improving involving the patient in decision making about their own care is very important. So that what I would like to say for question number 3. Thank you.
Yeah, so what I want to tell you about this, see, when you talk about sterilization or contraception, usually it is a family decision. So husband and wives are usually involved. Maybe the husband wants to have a baby, the woman doesn't want to have the baby. So you might come across in many situations where there's a challenge, ethical challenge which you have to resolve. One of the persons wants to have one, and just the opposite, the other is asking. So whom you are bound by a patient-doctor relationship. You as a doctor and as a patient, whom are you supposed to listen to? Maybe the money is paid by the husband for your treatment, but you're treating the wife. So there's a conflict within yourself. Whom am I responsible to? Both are asking for two different reasons. Whose reason are you have to protect? Then what happens is you must think about the health of the person. If the mother's health is not very good, if you think, yes, this lady is very weak, she might not have a baby, it might not withstand her pregnancy, could be a high risk, then it's necessary for you ethically to protect her. So you take a decision. Yes, my decision is for the woman health. Therefore, I'm here as a doctor to protect her health. I will, if the pregnancy is going to affect her health, I should prevent the pregnancy. I should give correct contraceptive advice. If at all, even talk to the husband, tell him yes, pregnancy should not take place, and convince him that let's wait for some time, let her become healthy. I'll give her medicines to make her healthy, and then we can have a pregnancy. You might even come across sometimes the husband saying, no, I want to have a child. I want her to become pregnant immediately, not listening to you. At that time, if she's pregnant and she wants to have an abortion, you are right to protect her health by even misleading the husband by telling her that this abortion was spontaneous. You have not induced. You are not the cause of the thing. It is God's decision to have this abortion. You can tell a partial lie, but because end of the day, you're protecting health of the woman. We as doctors, we are here to protect. And if that means that we might have to tell a lie, it's okay. So that's the meaning of this whole thing. At times, we have to do things in the benefit of mankind, benefit of women healthcare. Yes. Third.
Thank you so much.
Moving on to the case 3. Shreya, you can go ahead.
Adults in sex education. Should Dr. J. Kumar offer sexual health information to the students? Yes, I definitely think it is very important for the Dr. J to give sex education to the students, because between the age of 11 to 16 is the age to have more prone for this for having all the sex things and all without knowing its ill effects. So educating them would help them understand what is the meaning of it. And especially when it comes to the age group of around 10 to 11, the kids don't understand what is a good touch and a bad touch. And since they're very small kids, they don't know what is a bad touch and what are the ill effects. So I think Dr. J. Kumar should definitely offer his knowledge about sex and what are its ill effects like STDs and pregnancies. And the second question is, what is Dr. J. Kumar's ethical duty towards the students and the parents in the situation? In India, especially in the southern part of in India, I think most of the parents aren't willing to let their children know about all this adults and things, because they find that is a matter of an adults. But I know it is difficult, especially when it comes to the terminology. When because people are grounded here, they don't want their kids to know the adult language and all. But still, I think Dr. J or any doctor in the position should help them understand what is sex and what are the things that are included in it in a terminology that both parents and students can take it at a same pace. Because students at 11 to 16 are usually like, even if I go now, go take a class about sex, kids would be would be left just laughing without actually understanding what the depth is. So I think the kids should be told in the language they'll be able to take it. For example, instead of just saying you shouldn't go on a date, you can just say that, like, today there are more cases of the marital rape and also date rape, where the kids don't know that there is a limitation and there's a consent. So sex education isn't just telling about the parts involved, but actually telling what is a consent and what are the ill effects, like STDs and getting pregnancies. And 11 to 16 is definitely an illegal age to have that. And even if they're getting pregnant or whatever, there are a lot of things which they won't even able to understand. For example, pregnancy. Recently in my hospital, there has been a case registered of a 16-year-old girl. She's just doing her inter second year or so, and she didn't even know she was pregnant until she came back to the hospital because of the severe abdominal pain. Just in a few moments itself, the baby got delivered, and she didn't even know, of 9 months of period, she didn't even know that she was pregnant. I think educating her would definitely, in the first way, prevent her having getting pregnant, and second way, it would definitely provide a good health to the baby itself.
Yeah. Yeah. So the second part of the question, what I meant was, what it is an ethical challenge when you're dealing with the parents sometimes. The parents of these young adolescent children, sometimes they don't want their children to know about sex education. Why? Because they think school will tell them about contraception and things like that. Yeah, in many religions, using contraception itself is a crime for them. So, abortion and contraception is no to many religions. So therefore, it's still debated in the West about abortion. So it's a big decision for them. So what I'm trying to say is, religion plays a big part in the social life of India. And who are the, so when you're talking to children and the parents think, oh, you're going to talk about their religious feelings and hurt them, and they will not let the doctor go and talk about sex education to children because they think they are violating their own uh, religious morals. So, in this times, it's important that ethical challenges is you not talking to the adolescent, but to talking to adolescent's parents. So you need to counsel the parents that you're doing something good. Sex education is part of the goals of all education, what education means. Not just reading a books, it's also sex education. Talking about sex is also part of education. And that is nothing wrong. You're not talking about religion. So that fundamental principle has to be taught to the parents. So they're not hurt and they will allow the child, because end of the day, the parents are guardians. You can't teach anybody without their consent. You need to get the consent of the parents. And that's the essence of this topic was adolescent sex education means not just sex education to children or adolescents, also means getting consent from the parents. So just don't give knowledge to the adolescents. Get the consent from the parents, otherwise you will land up in trouble one day. Next.
Okay, so moving on to case 4. Pragya, Avilin and Kashiva, the floor is yours. Please go ahead.
Case 4, conscientious objection of pharmacists and access to emergency contraception for rape victims. So the first question is, can emergency contraceptive services be denied in a public hospital on the basis of the conscientious objection of pharmacists when the drugs should be lawfully available? According to the Government of India, emergency contraceptives cannot be denied to any person irrespective of their age or marital status. There have been a number of studies why the emergency contraceptives are not available as easily compared to other drugs. It has been noted that there is a misunderstanding between emergency contraceptives and abortifacient drugs among pharmacists. Many of them are under the misinterpreting the fact that emergency contraceptives are not abortifacients, as they are interfering with ovulation and making the endometrium hostile. Thus, there is no fertilization or implantation or any embryo formation to take place for it to get aborted. It is preventing the entire process altogether. In fact, emergency contraceptives are provided to all patients, even if they have angina pectoris, migraine, or severe cardiovascular complications or severe liver disease, because they have been included as category 2 under WHO medical eligibility criteria. Only LNG 0.75 twice have been approved by the Government of India as an emergency contraceptive in India, and it is the duty of all medical personnel to provide this to whoever is asking for it, irrespective of their age or marital status. The second question is, what can Dr. Girish do? Dr. Girish primarily has a dual role to play in this situation, where we have a minor girl involved and it comes under the POSCO Act. The first is that he would have to provide medical treatment and psychological support irrespective of anything. And the second part is the medico-legal proceedings for collecting evidence and ensuring proper documentation. In this situation, the victim has refused to put any instruments or any object inside her because of her fear. So, according to the Government of India, the victim or the person who gives consent for her, as she's a minor, has the right to refuse this medical legal examination. And in case such a medical legal examination is refused, the doctor cannot proceed with further examination, but he has to provide medical treatment as well as inform the police regarding the same. As well as in this case, Dr. Girish, being a male RMP, cannot perform an examination directly. According to the POCSO Act Section 27, in case of a minor girl below 18 years of age, only a female RMP employed in a hospital run by government or a local authority can perform a medical examination, or if in case of absence of such a practitioner, any other registered medical practitioner with the consent of the victim as well as her guardian can perform an examination, which in this case might not be possible since the female is not willing for a medical legal examination. Had it been that Dr. Girish had taken a female RMP along with him and talked to her in an empathetic manner, maybe she would have consented to the examination. The second part of it would be providing medical treatment and psychological support, as well as offering her emergency contraceptives. Now, there are a number of things that he would have to take into consideration. One is to get a detailed history regarding her last menstrual period as well as a menstrual cycle, so as to rule out the possibility of a pregnancy. Even if the patient is already pregnant, there is no contraindication to an emergency contraceptive whatsoever. And he would also have to ask what was the how much time has lapsed between the last unprotected sexual intercourse, as emergency contraceptives are said to be most effective within 72 hours and can be used up to maximum 5 days. He would also have to explain the correct dosage, the mode of action, the possible side effects, and also that there would be a need to follow up in case that her next menses is going to be late by more than 7 days, or where there is menstrual bleeding is very scanty in her next menstrual cycle. He would have to take her age into consideration while also disclosing the fact that regardless of the use of emergency contraceptives, there are chances that the client can become pregnant as they are not 100% effective, and that she might require an MTP later on if she is willing.
Yeah, well done. I think you've spoken well.
All right. So, what ethical dilemmas is Dr. Girish facing in this case? Firstly, it is respecting patient autonomy. The young girl has the right to make decisions about her own body and medical treatment. She does not want to become pregnant and is entitled to emergency contraception if it's legally available. Secondly, is the conscientious objection. The pharmacists have the right to object in providing the emergency contraception based on their beliefs. However, this conflicts with the hospital's obligation to provide necessary and legally approved medical care. Thirdly, the dilemma is forensic evidence. Dr. Girish needs to obtain forensic evidence to assist in the legal proceedings against the assailant. However, the girl's resistance complicates this process. So, how can Dr. Girish treat the young victim appropriately? As mentioned, Dr. Girish should respect the girl's wishes and provide her with the emergency contraception, explaining its purpose and the potential benefits. He should ensure that the girl understands her options and provide emotional support as well. While the pharmacists have the right to object, Dr. Girish is the medical director here, and he should ensure that the emergency contraception is provided. So he could involve pharmacists who do not object to dispensing the medication, or he could also explore the possibility of bringing in external pharmacy staff temporarily. Next would be, what ethical and legal responsibility has Dr. Girish towards providing emergency contraception to the young girl? While healthcare professionals have the right to conscientious objection, they also have the duty to provide essential and legally approved medical care. In this case, the hospital's obligation would be the patient's well-being, and this might override the pharmacist's objection. So, emergency contraceptive services should ideally not be denied in a public hospital based on the objection of the pharmacist. So, the hospital administration should find a solution that respects both the patient's rights and the pharmacist's beliefs by involving staff who do not object to this and finding alternative arrangements without compromising the victim's timely access to care.
Well done.
Okay, the next question. What boundaries may Dr. Girish have in refusing treatment on grounds of the consciousness objection? So the first boundary that Dr. Girish may have is going against the wish of the pharmacist, or more like their beliefs, but he is bound to a situation where he might have to do it because a patient's safety is coming in the first place. So he could probably explain it to the pharmacist in a convincing way and in a way that they could understand. And if not possible, he can take the aids of external pharmaceutical agencies. What should Dr. Girish do about obtaining forensic evidence from the young victim? Okay, since the victim was not ready to have any external instruments to be used, he can convince the victim about the importance of the forensic medicine evidence and how it would help in providing justice to her. And even if she's still not ready, he can go for collecting those evidences that are available on the external surface, like any sorts of bruises or any sorts of scratches, which might provide justice to a certain extent, but definitely not as perfect evidence as the one that he would obtain upon completely examining, but he can explore that option as well. And about the ethical and legal responsibilities that Dr. Girish has to provide. He has to keep in mind the choices of the pharmacist as well as the choices of the patient, and should make sure that both of them are comfortable with the final decision that he is going to make, and make it in such a way that it is going to be beneficial for the patient and at the same time is convincing for the pharmacist. Thank you, sir.
The main thing I wanted to all the questions were well answered. The main thing I wanted to highlight in this was in case of rape victim, it's very important to give medical care and keeping confidentiality of this patient, of this rape victim, is the foremost duty of every doctor. Okay, so at any state you need to give medical treatment. That is the first most important. There's no question of any objection by anybody. Treatment and preventing the victim from becoming pregnant, and because pregnancy itself is a big scar for a rape victim. So therefore, that's our duty to prevent such a thing happening, and it's much above anybody's objection. Okay, thank you. I think.
So can you just give an overall feedback to everyone about the case presentation in a one line or two?
Very well done. All of you have got well into the reasons behind all these questions. So we've framed the legal aspects. You have studied very well, and I'm quite proud of all of you of what you have done. In-depth studies you have done in this topic, which has not been taught to any of you. I'm very proud of all the participants who have presented that cases. Very well done. Congratulations.
We're glad, sir, that you liked it. We just have one or two questions and then we let you go because we know your time is really crucial and important. So, Ishnu, go ahead and please make it quick.
There were a few questions put forward. First one was if you were telling that any sexual contact, even kissing before 18 is a crime.
Yeah.
But if both the partners in there are minors and they say they have given consent, so should we report both of them in case they approach us?
Yes. Remember, consent minors can't give. If you for anything, any procedure, you can't. Even if you want to give an injection for a child, you must get consent from the guardian. So therefore, that's the foremost thing. So there is no question of them agreeing to have sex. First of all, nobody can give consent. Their mind, according to Indian Act, the Parliament, they think anybody less than 18 years cannot make decisions for themselves. Their mind is not fully developed. So that they don't have capacity, they don't have competency to make a decision. Making a decision in life is most important. You all have made decisions to become doctors. So that is very, very important. So same way, a decision can be taken only if you are 18 years. Less than 18 years, that decision is to be taken by the guardian. So if two minors are having sex, there's no consent agreement.
So the right thing to do is to report both of them.
Yes, both of them.
Yes, so there was one more question regarding the case 2 in the case presentations. So you were mentioning that if there is no health reason, like you were mentioning health reason as one of the key points to base our decision on.
Yeah.
So the question was, if there is no health reason, there is no genuine health reason to support or deny it. A patient is perfectly healthy, but the woman wants the sterilization procedure and the husband wants a child. Though the husband might have been paying either way for any case. Even if the woman wants a sterilization procedure, should we not give it to her then? Because the husband is paying for it. You mentioned that we have some responsibility towards the person who's paying for the procedure as well.
Yeah.
That was the question.
Yeah.
So
the question, yes, yeah. Now you have two people. You see, because it is regarding having a baby, family. End of the day, it comes to it's the right of the woman to decide what she can do with her reproductive rights. There's something on reproductive rights. That she wants to have a baby or not, it's her rights. But when it comes to family, it's, a husband has a say. But the final thing comes to a woman. So is the woman, whatever a woman asks, it's your duty because she's your patient, finally, is for you to listen to her. Her autonomy comes foremost. But all the more important is to bring it to the knowledge of the husband. Always a sterilization, you need to have a husband consent also. It's better. In doubt, let the court decide.
Okay.
Let the court decide. You don't take responsibility. They don't take responsibility. Learn about that. But when you make a mistake, take responsibility for the mistake. Otherwise, don't take responsibility for it.
Okay, sir. So ideally, women's consent is alone enough, but it is better to take both.
Both.
Both. Yes,
because
sir.
under reproductive rights, it's a woman. It's her body. It's her right to decide if she wants to have a baby or not.
Okay, sir. There was another question, which was, I think, a little philosophical question. You're mentioning that in the assisted reproductive act, you're mentioning we should not try to play God.
Yeah.
That is the motivating idea behind the act. So our question was, why is it wrong to want to have the best traits for your child? Isn't all medical care trying to play God? Aren't we trying to fix problems that would have earlier been left to God, but because we are meddling with it? No, isn't this also in the same vein? Therefore, why shouldn't we want this best traits for our child? Is it so wrong? Is the question.
Because you're not certain. Medicine itself is uncertain science. You can't guarantee anything in science. You can't guarantee that you're going to give them the best child. How can you guarantee? When you can't guarantee, how can you advertise? How can you say that only God can say what can happen? God only knows what will happen. That's what God is for. He knows what will happen. Humans don't know what will happen. We are uncertain. When we are uncertain, we cannot play God. We can't. It's unfair trade practice. That's what we say in Consumer Act. It says you can't unfairly practice your trade by giving a wrong idea to your patient that you can do these things. Okay, so you cannot promise most healthiest child, even whatever reproductive I will test tube baby you're doing, 100% you can say this child will be the healthiest child or the strongest child, designer baby, all that. It is not going to be, it's not going to happen. Ethics will not allow.
Okay, sir. Thank you. With that, I think we can close the session, close the floor here. Thank you, Vivek, sir, for joining us today. Your insights have been very valuable to us. There were a lot of questions that only you would have been able to answer, and you have answered it for us. So thank you once again, sir.
All the
With that,
best.
I'll hand.
Yeah. All
Yes.
the best. Become good doctors. That's all. Try to be the good doctor. Do good to your patient. That's what I want to tell you all. All the best. Have happy Diwali. Enjoy.
Thank you very much, sir. With that, I'll hand it over to Chaitanya.
Thank you, sir. It's really been a privilege talking to you. Arnab, are you there? Just close the live stream, please.
All the participants, if you have any words of appreciation for Vivek, sir, please drop them in the chat box. We will forward the same to sir. If anything you wanted to appreciate, sir, for the session, please do so in the chat box. We'll share it. We'll forward the same to the sir.
We'll just take a small break of 2 minutes and then we'll proceed with the presentation there. So the first group will be group 3. So just be ready in the meanwhile. I'll call you upon again. Okay, so group 3, are you ready? Please, the group moderator and whoever the presenter is, start your presentation. As soon as you share your screen, I'll be starting the timer. The time limit is 5 minutes only. Good luck. Can the presenter unmute and start the presentation? So she is Astha here.
Yes, she is there on the meet.
Hello, am I audible?
Yeah, you are. Okay, go on with the presentation. Sharing the
Can you
screen.
share it? Yeah, thank you.
So the timer will start now.
Okay, so okay. So our topic is promoting STEM education in women. Just to be clear with the basics, STEM stands for science, technology, engineering, and mathematics. So beginning with the SWOT analysis, the strengths include empowering women and providing them with more economical opportunities and including more diversity, creativity, and innovation in the pre-existing STEM fields. The weaknesses are the gender stereotypes, underrepresentation of women, especially women of color, and the absence of prominent role models in STEM fields. The opportunities include increasing industrial demand, awareness among the general population, and advocacy policies and support programs. Whereas the threats are the gender bias, patriarchy, educational barriers, and struggle in maintaining a proper work-life balance. Talking about the core message here is that STEM education is crucial for women as it provides them with opportunities, education, and skills like problem solving and critical thinking that will help them in all respects of their life and foster more innovation and creativity in the field. Research studies across the world state that hardly 30% of the students and workforce in STEM are women, which strongly indicates a gender disparity. And one of the prominent reasons behind this is the perceived notion of not being able to maintain a work life balance, since women are still expected to make endless sacrifices and be the primary caretaker of their families. But a recent and welcome change in trend has been seen in a lot of companies as they include gender inclusive policies and promote gender neutral workspaces, along with government advocating the same via initiatives like the Vigyan Jyoti and Vigyan Prasad. The problem is gender stereotypes and biases discouraging women from entering STEM fields. It negatively impacts women by preventing them from exploring their interests and men as well by creating male dominated workspaces that may grow to be toxic. Evidence come from a lot of research studies like one done by the AISHE that states that only 26% female students pursue higher education in STEM in India. And the major responsibility lies the notions of the society that have been passed down since ages about patriarchy and gender biases, and the lack of very active initiatives being taken by workspaces, companies, the government, and educational institutions. The solution can be exposing girls to STEM education at a very young age and supporting and creating media content that highlights the women who are already succeeding in STEM. It'll benefit them by providing them with self confidence and aspiration and creating a more balanced workspace. The studies have also shown the same, and the action can be taken by government by providing scholarships to women in STEM and the media by promoting positive portrayal of the women who have already succeeded in this field. We have some policies framework which we want to state, like the schools must provide mentorship and career guidance to young girls to pursue higher education. The universities and college students can tie up with schools to impart practical knowledge and workshops about STEM subjects at since a very young age. Scholarships and grants can be given from the government to women who are pursuing their higher education in STEM. And these schools can also go with a credit based system in which they provide credits to students who take up robotics workshops, mathematics seminars, science fairs. And these credits can later on go on to provide them with rewards and scholarships. NGOs can also take up this cause and help in connecting women across various geographical regions who are excelling in STEM. So, thank you.
Okay, great job. The next group is group 1. Chirag, please share your screen. The presenter can Can the presenter unmute and start the presentation?
Okay.
Okay, so your time starts now, Satika. Go ahead.
Okay. So the topic for Group 1 is need for gender inclusive healthcare policies, and we will begin with the SWOT analysis. Sneha, can you take over?
Good evening, everybody. I'll be going ahead with a SWOT analysis. So, coming to the strengths, equity and access. Gender inclusive policies promote equal access and healthcare services to all genders. And this ensures that the same quality of care is given to everybody. Improved health outcomes. Every gender has their unique healthcare needs, and improved health outcomes can only come when we recognize this diverse population. Reduced health disparities. This can mitigate disparities in healthcare access and outcomes and make it a more equitable healthcare system. Enhanced mental health support. Mental health needs are specific to different gender identities, and as soon as we recognize these and cater to these, we can have better health outcomes. And coming to the weaknesses, implementation challenges. This is especially seen from traditional practices and ingrained biases. And sadly, this applies to both women and the LGBTQIA plus communities. Some individuals, including healthcare professionals, um, have their personal beliefs and lack of understanding, which creates a barrier in the effective implementation. Lack of education and awareness. This is seen not only in general population but also healthcare providers. That again uh, is inadequate implementation, a very big cause of inadequate implementation. Policy gaps. Oftentimes, we come across incomplete or vague policies that leave room for interpretation, leading to inconsistencies. This, again, another very big reason. Financial constraints. These implementation of these policies may require a lot of additional resources, and this leads to a very big challenge when it comes to widespread adoption of such policies. Coming to opportunities, this is where we need to focus on education and training to the healthcare providers on gender sensitivity, diversity, and inclusion. Name and pronoun uses. When we do this, we foster an environment where they feel respected and they feel safe. Non-discrimination policies. This needs to be implemented strictly. When it comes to patient intake forms, this can be made more inclusive by adding pronouns and being more inclusive in these terms. Advocacy and awareness. This can be done at local, state, and national levels. Raising awareness about the importance of such policies, again, another, it can give a uh, push to the policies. Collaboration with LGBTQIA plus organizations and policymakers. Regular policy interview. Periodically, this needs to be done because gender and its understanding is in itself evolving. Threats. Coming to threats, we have resistance and bias again by healthcare professionals and general population, policy reversals, incomplete policies, inconsistencies, lack of research and data. This is very, very important. We as healthcare professionals need to focus on this. Stigmatization. Individuals who identify outside of traditional gender norms face stigma and discrimination, which needs to be worked on. And inadequate training. Healthcare providers need to be trained, properly educated, um, to give optimum care and healthcare to such individuals. Sadhika?
Yeah. So coming to the core message, the problems currently present with respect to gender sensitization are numerous, but the ones that stand out are lack of sufficient training for healthcare professionals, lack of data collection, challenges on gender identity to address diverse gender groups, presence of mental health disparities. And to give examples, there's a 2018 study that says doctors often view men with chronic pain as brave or stoic, but view women with chronic pain as emotional or hysterical. And there are many scientists that believe that males are best test subjects because they do not have menstrual cycles and cannot become pregnant. But as we all know, important biological differences exist between sexes and can influence how diseases, drugs, and other therapies can affect people. Now, coming to the policy, there can be a number of solutions that can be implemented that include to conduct regular training sessions for healthcare professionals to enhance their understanding and of gender diversity. We can collaborate with LGBTQ communities like NAS Foundation Trust, Humsafar Trust, etc. for funding and resources to include gender identity and expression in health data collection to understand and address specific health disparities while respecting their decision to not reveal the same. We can support research initiatives focusing on gender-specific health concerns and encourage mental health support groups and increase accessibility to mental health services. We hope that such policies will come into play in the future and the wide gender gap can be brought down. Thank you.
Okay.
Okay, so just one suggestion that do not, like you all took a lot of time on SWOT analysis, whereas core message was the most important one. Okay, so keep that in mind. Next is group 7. Vaibhavi, are you here? Chirag, you
Yes,
can stop
hello.
sharing your screen.
Hello, am I audible?
Yes, you are. Go ahead. The time will start now.
Good evening, everyone. My name is Supriti, and I'm presenting Group 7's discussion topic, that is harmful traditional practices. Before we begin, I just want to talk about what are harmful practices. These are any practices or behaviors with aggressive or microaggressive intentions that seek to suppress a group of people, usually minorities, on the basis of discriminatory grounds such as sex, gender, religion, etc. Can you please move on to the next slide? So firstly, harmful practices can be of three types, that is traditional, emerging, and re-emerging. Today, we will be discussing traditional harmful practices solely in India to confine our discussion and provide more clarity. So the strengths, what has been done to combat this issue within the Indian context? Our strengths include the awareness programs that have been aimed at community outreach and education, like Beti Bachao, Beti Padhao Andolan, and establishment of laws and legal framework. However, we still have a lot of hurdles to overcome, such as community resistance and lack of enforcement. And there have been a lot of upcoming initiatives and activities by NGOs and activists to combat specific issues, such as NGO activities like Girls Not Brides Work and Technology for Education. Threats. There are still threats being faced by such initiatives, such as deep-rooted traditions and economic factors that limit the extent of the impact. Now let's talk about the core message that we want to convey. Firstly, what is the problem? As I just discussed, this is the definition of harmful traditional practices. And such examples in India include child marriage, sati, dowry violence, female genital mutilation,
honor killing, Devdasi system, conversion therapy, etc. How does it affect people? For the victim, there is a decrease in overall health, including physical, mental, and social, and there is a decrease in participation in community inclusion, and there is also a decreased educational and economic and social status. What is the evidence? As you can see, the statistics displayed, 145 honor killing incidents have occurred in India between 2017 and 2019, as explained by the government in a Lok Sabha meeting. And more than 7,100 dowry deaths have been reported in India in 2019, according to the National Crime Reports Bureau. And 90,000 Vedasis in Karnataka are below 18 years of age. And this was explained by a foreign NGO and Karnataka State Women's and University study. And to outline a human example, this is a recent case that happened in Karnataka, and this was a case where a woman who had just delivered her baby was forced to stay in a makeshift hut outside her village. And as a result of this, it was the monsoon season, and the the infant immediately died because of respiratory tract infections. Who is responsible because of this? We can see that there are negative religious beliefs, patriarchy, mob mentality, lack of awareness, and retrospection that play an important role in situations like these, according to a study published by Jennifer Glover et al. The solution is mostly awareness and education. That is the most important element of this. Introduction of new laws, creation of safe spaces, support groups, etc. are very important. How does it benefit people? It has a lot of effects for the victims and people who have gone through this before. It can be very motivating to them, and other cases, other victims will be motivated to come forward with their stories and their scenarios. What is the evidence for this? Anti-sati laws, and there's this incident there was a domestic abuse survivor who found a lot of motivation and encouragement through online friends and support groups to come forward with her story. And the role of national family health surveys and helpline services have been found to increase mental health uh, seeking therapy. There is I can't see the screen sharing. Okay, yeah. So the helplines have been found to increase people coming forward to therapy, as found in a study published by Apeksha Suraj in 2023. And we can move on to the policy framework now. The policy framework includes government and policymakers, NGOs and advocacy groups, educational institutes, medical professionals, media and communication platforms, and international organizations that provide support. Thank you.
Okay, so one feedback I'd like to give is the font that was not maintained because I specifically sent in a message. So
Okay.
great work. And
Thank
I think
you.
there's a problem with Vaibhavi. She was not the co-host. No problem for that.
Yeah.
The next is group 5. Rehan, are you here?
Hello.
Yeah,
Yes,
I'll
ma'am.
share the screen just a sec.
Okay.
Okay, Rehan, go ahead.
Yeah. So a very good evening to everyone. The topic for our today's discussion is gender neutral approach in prenatal care. Moving towards the SWOT analysis we have. What are the strength of this topic? There, it leads to this analysis has led to a decrease in the number of female feticide. What are the opportunities we have? We can balance the sex ratio, and the mistreatment in maternity care can be prevented. Moving to the weaknesses, there is lack of awareness. There is a corruption in the healthcare system, which I'll be discussing in my core message also, and setting up more number of centers and illegal sex determination. The one that quacks are doing nowadays is very common, and we all of us are aware of that. What are the threats we have related to this issue? A negative attitude towards the healthcare, basically of the medical professionals only, and the misconceptions regarding gender of the fetus. So moving towards the core message we have, what are the problems and what is the main problem? The main culprit of this prenatal sex determination are those greedy medical personnel who consider money to be their first and foremost priority, keeping all the ethics of this noble profession at stake. So at very first, we need to bring a change at our part by making our medical workers more ethically and morally aware. Then how does this problem of gender determination affect the people? It directly affects female population by decreasing their number, obviously, and indirectly affect the healthcare of the health of the society, the structure of the society. What are the evidences? The most common evidence is the declining sex ratio. Outlining it with a human example, we have the child sex ratio, which is the number of girls per thousand boys in 0 to 6 years of age has declined from 976 in 1961 to 914 in 2011. The child sex ratio in the state of Maharashtra declined from 940 in 1991 to 913 in 2001 to 883 in 2011. Child sex ratio in the state has declined at a rate of 3.28% between 2001 and 2011, as against 1.4% for the country. Now, who is responsible for it? All the stakeholders, including greedy healthcare personnel, parents who have a burning desire to have having a kid, a male kid, and administration who failed at proper enactment of these laws. So, what is the solution we have? A strong enactment of the present law, with simultaneously increasing awareness among the people. How will it benefit? It will help in maintaining the natural balance and structure of the society. What are the evidences for it? According to a Journal of Development Economics, Volume 103, published in July 2018, page 216 to 228, there has been a after enactment of PCPNDT Act, it has account for an increase of 14 to 26 points in the child sex ratio. Now, what needs to change and who needs to change? First and foremost, mentality of people related to a girl child needs to be changed. The ignorant and let go attitude of the concerned officials, basically the administration, needs to be changed at the same time. What are the actions which needs to be taken and by whom? So first and foremost, the administration should go on with the strong enactment of PCPNDT Act with zero tolerant policy needs to be undertaken. Also simultaneously making people aware of importance of a girl child in the society, as the slogan says, "Beti jalaoge to bahu kahan se lao." Moving with the policy framework, we have three main parts: inclusive language provides the training and personalized care, main three, and followed by privacy assurance and inclusive education. In inclusive language, we have to mandate gender neutral terminology in all prenatal materials, so that the patient must not have any idea about the sex of the developing fetus. Provided training, we have to implement training to sensitize healthcare professionals to diverse gender identities. For personalized care, we have to establish guidelines for flexible, personalized prenatal care plan. And secondly, for privacy assurance, it is very important as we have to ensure private and respectful spaces, allowing choices of healthcare providers gender. Inclusive education, we have to integrate diverse and inclusive health education into prenatal resources and classes. Thank you.
Okay, you finished well before time. Good job. So the next team would be group 10. Sanika. Sanika, are you there?
Hello. Yes, I'm trying to.
I cannot hear you, Sanika.
Hello.
Yeah, go
Hello.
on.
Yeah, I'm trying to share, but I'm facing some issue.
Do you want me to share on your behalf?
Could you try it one
Is
time?
the editable link the same, right? You have not made any changes.
Not any changes since the last
Okay,
day.
okay, I'll do it for you later.
Thank you so much.
Okay. The speaker shall go ahead.
Good morning, one and all. This is Faiza, hailing from Group 10, and our topic for presentation is social support for women and children in conflict zones. So, first of all, we would like to start with the SWOT analysis over here. SWOT analysis stands for strengths. Here, first of all, strong social cohesion among the communities is required, then contribution around the globe. Stakeholders agencies should be involved in this with social mobilization and with quick, efficient throughout the field, people representing all group of people. Next, moving on to weaknesses, the main identifiable weakness lies in mainly what is the lacking of preparedness for large scale of disasters, what we have to do. And coordination is the second thing, language barrier and cultural dependency, which is a great issue over here. Next, we have opportunities. In spite of all these weaknesses, we can see that many government and non-government groups have been involved. uh, they are extending their helping hands for this, and there are many windows of opportunities for developing the policies. After this, threats. These undermining these services, potential of undermining these services, lack of understanding among the people, and exploitation of vulnerable people, vulnerable survivors by the unskilled research. Now, next, moving on to the core message, where we are going to discuss about a problem and its solution. What can we provide to it? The main problem we would like to discuss over here is post-traumatic stress disorder and depression. So for this, we have solution. Being a medical practitioner, we can just provide the people not with just physical or whatever the wounds that have been visible to us. We can also provide them with we can heal them with invisible wounds as well. So as we know the definition of health, that is near not just physical well-being, but also social, mentally well-being is also required nearly of any free of any diseases. So next thing is about how the people are being affected by this. It's a widespread insecure. As mental health is indirectly proportionate to whatever the social economic development of the person, physical, mental, and economy of this thing. Uh, so this might help. This will affect the person in everything development. So how can we? By providing mental distress behavior and as they are coming out of those kind of social psychological things and all, we can develop persons socially, economically, and physically as well. Next thing is how did we the evidence as all the whatever the Uganda, Syria, and not only these all and now we can see the recently that is happening, that is Gaza attack. These all things are the evidence of these people. Whatever the future they have been planned, have been halted by all these things. Just with little things, we just burst out that that hasn't happened. In a similar way, these are the great examples in front of us. So what can we do for solution? Not just by the decade of long civil war, but also recent Ebola attack. Now we they for this when we just try to develop with the solution, we can move forward by these all the solutions what have been provided to us. Next thing is yeah, the 1911 war can be one of the great example of this. How US and Japan have great developed from the whatever the crisis they have been affected, and Japan after Hiroshima and Nagasaki's development. It's all because of the mental health they have focused on their mental and physical. They have coordinated with all those things. So after this, what is the solution? Who need to change? Is the people, world leaders, and lawmakers, and there should be no religion-based bias if whatever need to be there. Then after that, another thing we would like to do is who are responsible. Yeah, who are responsible for all these things? We can just move on. Next, moving on to policy framework. The capacity for bringing primary response for triage and modification, that is local stakeholders and constant standby team, whatever the military personnel we have, we need to train them by developing them, like being prepared in earlier way. Modify the trial system, like for we whenever there is any kind of emergency, We start with initial assessment by strengthening those things, by community strategy, by clear communication with the people, research and resources integration. Whatever we have, whatever the available resources we have, we can just gather it in prior stage and just thinking out of the box or the things whatever available. Next we have is the
Time is up.
yeah. Okay, thank you.
Okay, it was a good presentation. The next will be group 4. Shreya.
Yes, I'm sharing the screen.
Okay, so the time has started. Kashifa, go ahead.
All right. So good evening, everybody. On behalf of Group 4, I will be presenting the presentation, and our topic is abolishing child marriage and labor. Next slide, please. Okay, coming to the SWOT analysis. Next slide. Okay, so what would be the strengths when we abolish child marriage and child labor? So firstly, there will be global awareness and advocacy, then followed by legislation and international agreements. We can also have engagements from the NGOs and the community. And the another strength would be that public outcry against exploitation would create pressure on the governments, industries, and the communities to take actions. Now, what would be the weaknesses in this process of abolishing child marriage and labor? So the socioeconomic factors come into play. Cultural norms and the resistance to change is also influential here, with the lack of education and awareness, and definitely there will be challenges in enforcing all the actions which we want to do. So what are the opportunities where we can employ this? So through technological advancement and corporate social responsibility and empowerment through education. What would be the threats over here? Because of limited resources and funding, political instability, and economic downturns, the issue is that it might be difficult to abolish child marriage and labor. Next slide, please. Next slide. Okay. So coming to the core message, what is the problem here? So we need to consider child labor and child marriage in depth. So over here we can see that child labor deprives children of the right to education, their occupational hazard exposures, hindering their physical and mental development, which will perpetuate a cycle of poverty and limits their future opportunities. Whereas child marriage deprives them of childhood, especially the girls, exposing them to early adulthood, resulting in negative health outcomes, which perpetuates gender inequality and denies the girls the chance to pursue education and fulfill their potential. How does it affect people? So, firstly, there's exploitation and abuse, there's denial of childhood, and then there's economic dependence because child brides they don't have the skills and the education needed for economic independence, which is why they become economically dependent on their spouses, which will reinforce gender disparities and limiting their ability to make choices for themselves. So, what evidence is there? The International Labour Organization has stated that 160 million children are part of child labor, and certain groups like Girls Not Brides and NGO reports from UNICEF have estimated 640 million girls and women alive today were married in childhood itself. There's a staggering 45% from South Asia, followed by Sub-Saharan Africa 20%, East Asia and the Pacific at 15%, and Latin America and Caribbean at 9%. India alone accounts for one-third of the world's child brides. And this is an equal share compared to the next 10 countries, which will be accounting for the next two-thirds, and the other two-thirds would be from 190 plus countries. So let's take a context of a rural village in a developing country with limited economic opportunities. And this village relies heavily on agriculture, and the poverty is widespread. With limited access to education and few alternative income opportunities, this increases the incidence of child labor and subsequently child marriage as well. So who is responsible for this? The government, the international community, the employers, and the industries. Not to forget the communities and the families as well. So what is the solution? We need to consider that both issues violate fundamental human rights. So this requires a multifaceted approach involving legal, social, and economic measures. How does abolishing child marriage and labor benefit people? This creates education opportunities for girls and it improves the health outcomes, thereby breaking the cycle of poverty. So, what is the evidence that we are progressing in abolishing child marriage and labor? So, there is a decline by 94 million since 2000, and many reports have suggested that the target 8.7, that is, which is targeted for calling an end to child labor by 2025 and child marriage by 2030. What needs to change? Improve access to quality education, implement measures like scholarships or subsidies, introduce sustainable and alternative income opportunities, promote community-based initiatives, and strengthen enforcement of child labor laws. What actions need to be taken? The governments and the international community, the employers and industries and communities and families who are responsible need to be responsible for the solution as well. Next slide, please. Next slide, please. All right, so the policy framework highlights digital education initiatives, digital skill development, and community engagement and awareness. Next slide. That would be through curriculum integration, e-learning platforms, mobile learning centers, vocational training programs, entrepreneurship programs, digital literacy camps, awareness campaigns, parental education programs, and reporting platforms. Thank you.
Okay, so it was really good, too detailed, and the diagram is something that I like. I don't think most of the groups have actually put that much effort, but that effort is actually getting, minimized because of the core message. I had told to make it a little bit crisp, like exact pointers to be there. There are a lot of pointers, so it kind of, gets very tedious. Other than that, the diagram is really good. So the next group is group 8. Hardiki. Group 8, are you there?
Yes, ma'am.
Go on, Hardik.
Actually, I'm unable to do that. Give me a minute. Is it visible?
Yes, yes, it is visible. Okay, you can start now, Ria.
Good evening, everyone. I am Ria Singh from Group 8. Our topic is ensuring safe access to abortion. SWOT analysis. Strengths: availability of legal and safe services, adequate training of healthcare providers and medical staff, ensuring hygiene and prevention of post abortion complications through protocols, advocating reproductive and obstetric rights of women via awareness by health organizations and medical professionals. Weaknesses: limited access to women at grassroots level, unsafe practices by non trained individuals, malpractice by professionals, especially regarding female child. Opportunities: increasing awareness about reproductive rights, expanding telemedicine options, ensuring overall safer obstetric care. Threats: misinformation regarding legal and safe practices, unsafe and fatal practices by quacks, lack of adequate services, sterile practices, and post procedure care. So, moving on to the core message, the quality abortion care is the care that is effective, delivered by healthcare workers with the right skills, resources, and information, safe, accessible to all those that need it, timely, and respectful of women and girls' needs and rights. Abortion self care is the ability of pregnant individuals to manage their unwanted pregnancies with or without the support of healthcare providers, particularly in the early weeks of pregnancy. The advent of medication abortion has made this possible, as early self managed MA at home is a safe, acceptable, and cost effective method of pregnancy termination. The drugs currently available for MA are mifepristone and misoprostol, as well as the two packed together, which is more efficacious than misoprostol alone in evacuating the uterus and is considered the first line medication for MA. Poor awareness of the law, unnecessary spousal consent requirements, contraceptive targets linked to abortion, and informal and high fees also serves as barriers. Training more providers, simplifying registration procedures, delinking clinical and provider approval, and linking policy with up-to-date technology, research, and good clinical practice are some immediate measures needed to improve women's access to safe abortion care. The new MTP Act 2021 expands the access to safe and legal abortion services on therapeutic, eugenic, humanitarian, and social grounds to ensure universal access to comprehensive care. The new launch, which came into force from 25th March 2021, will contribute towards ending preventable maternal mortality to help meet the Sustainable Development Goals. So, the 7 key categories of respectful maternal care are as right to be free from harm and ill treatment, right to dignity and respect, right to information, informed consent, choices and preferences, right to privacy and confidentiality, right to non discrimination, equality, and equitable care, right to timely health care and to the highest attainable level of health, right to liberty, autonomy, self determination, and freedom from coercion. So, what is the problem? It is the lack of education regarding this, especially in rural areas. Social factors like burden from society, that what people will think if they got aborted the child, and misbelief that they will not be able to bear the child whole life, poor socioeconomic condition, female feticide, and the preference of male child over female. How does it affect people? There will be high mortality rates, complications using unsafe practices, and most importantly, the adolescents using Google medications like overdose of PCM. Who is responsible? A single person is not responsible for this, and we are no one to judge anyone, as social beliefs were also made by humans only, and we are there to correct our mistake. So, what is the solution? Educating people and clearing taboos regarding this through camps, ASHA workers, role plays, and in hospitals, ensuring usage of sterilized equipments, and most importantly, consent from the lady itself, telling her about the high risk pregnancy. How does it benefit people? If educated, it can reduce the mortality rates and protect our future generation. Who and what needs to change? Thinking. Thinking of people, as devil resides in our heads only. And in hospitals, we can improve the conditions by sanitizing the equipments, ensuring that the policies made are being implemented in a proper way. What action needs to be taken and by whom? Action needs to be taken by us as doctors by educating the women, and by the government to see the implementation of the policies made by them. Policy framework. Policies by the government. Make information about abortion services widely available and accessible. Provide abortion services in range of settings. There should be guidelines regarding medication of abortion for people who take pills instead of surgery. Policies by the healthcare providers. Facility requirements, medical standards and training, emergency protocols. Policies for the public. The public should be known with the concept of informed consent. The public should know or made aware of the complications. The public should know about the complications and the details of the procedure. We are grateful for this opportunity to learn great ideas and advocates our thoughts. We thank AMSA for organizing such knowledgeable and inspiring events for us. Thank you.
Okay. The thing I really like about this group is how you all actually elaborated more on the core message. Just like I mentioned, that is the most important thing. and the policy framework table is also really good. The only extra thing I think you shouldn't have done is like the first two slides of core message, because you have a time limit of 5 minutes. So those two slides have taken up your time, because the slides after that were very much more informative than those two slides. So next group would be group 2, Amisha. Hardik, you can stop sharing the screen.
Am I audible?
Yeah.
While
Amisha,
Amisha is like sharing the screen, I'll just introduce myself. I'm Manjari. I'll be presenting on behalf of Group 2, and our topic is reproductive health rights for women. So if Amisha, if you could just go to the SWOT analysis slide.
Can you see the screen?
Yes. So SWOT analysis, we'll be starting with strengths. So India has been working on the establishment of legal frameworks safeguarding reproductive rights. And the benefits include improved overall health outcomes, and awareness campaigns are being conducted to educate women about their reproductive rights. Moving on to weaknesses, there are many policies that safeguard reproductive rights, but they are not being mandated and there are no measures to ensure that they're being followed. There is also a lack of awareness in rural areas and lack of sex education, along with cultural and social resistance. Now, opportunities on improvements of these reproductive rights include one thing is reduction of stress about fertility and a global scale of education. This reduction of stress about fertility would also lead to less needs for egg donation. Now, the threats are a psychological impact when such a big, large scale changes are made in any policy, and also legal restriction may come into play in the future. Moving on to the core message, if you could change the slide, thank you. We have a problem statement that we took into consideration, which is official menstrual leave. So the problem is that many women in India face difficulties and discrimination in the workplace and in educational institutions due to menstruation. They have many social and cultural barriers that prevent them from openly discussing their bodily needs and challenges, like the fear of staining their clothes, dysmenorrhea, premenstrual dysphoric disorder, etc. It affects women with their finance, career, education, and thus their empowerment is compromised. And it also has a negative impact on the economy as it reduces their participation in the labor workforce. Now, evidence, there are quite a few studies. I'll be talking mainly about the 2014 study by Nelson and Plan India. So 66% of girls miss school during their periods. Other studies include a 2017 survey by She Says and a 2020 article by the Indian Express. Now, we are also outlining a human example. If we take the case study of Aisha, she's a 29-year-old software engineer from Pune, and she suffers from dysmenorrhea. Her company doesn't have a menstrual leave policy, so she has to work from home or take a sick leave. And she also faces discrimination and harassment from her male colleagues. Due to this, she feels ashamed and isolated, and she fears losing her job. Now, the general responsibility for this problem is first the attitude towards women. There was a public interest litigation regarding menstrual leave for workers and students, but it was rejected by the Supreme Court. And the media also does not portray positive, realistic images of women and their bodies, so it's indirectly propagating the silence and stigma and the misinformation around menstruation. Moving on to solutions, there have been attempts to introduce menstrual leave and menstrual health product bills, like I talked about earlier, but they have not been very successful. So if proper implementation of these already proposed policies is taken in the future, it's a very effective solution. And the benefits to people is, again, it improves their mental health, it improves their dignity and their safety. And evidence of a solution is shown in various studies again. The 2019 study by the University of Oxford suggested that free sanitary pads and menstrual education to girls in Uganda increased their school attendance by 17%. The Times of India, in an article in 2020, stated that the Guwahati University introduced a menstrual leave policy for its female students. It was the first university in India to do so. Now, the areas where change needs to occur is multiple levels: the individual level, the interpersonal level, the institutional level, and the societal level. This includes changing knowledge, attitude, and behavior of people, creating a supportive and respectful environment for women, and changing policies and practices of the government. And actions, it's an overlap with the previous topic, but actions need to be taken by all stakeholders. Stakeholders specifically are the government, the private sector, the civil society, media, and individuals. So at various levels, there are various problems which they can tackle. Moving on to policy framework, the next slide. An introduction to policies is that in India specifically, the reproductive health related laws have failed to take a women's rights approach. They instead focus on population control. There are some positives like the MTP Act, Article 21, and PMCA, which is the Prohibition of Child Marriage Act. And the main stakeholders I'll be talking about is the government and Supreme Court, hospital administration, and education centers. If we look at the problem statement that doctors refuse to perform abortions on young women or demand that they get consent from their parents or spouses for the abortion despite no law requirement, we have various solutions. One, the government has to improve their amendments to prevent such malpractice by the medical practitioner. The hospital should ensure that the patient has informed consent, and education systems should update their brochures and pamphlets so that the general public is aware of the current policies. We've listed our sources and the script in the acknowledgements and sources. Thank you very much.
Okay, so this was a really good presentation, especially the way you explained your core message. Because when you wrote evidence, I was actually going to note that point that you only wrote ki kaun se paper mein kaun sa evidence tha, but you didn't explain it. But then I'm glad that you explained it, and it was really detailed. I think that you really understand what you were saying. So good work. Next would be group 9. Gurnur.
Good evening. Am I audible?
Yes, Pranav, you're audible.
My name is Pranav, and I will be presenting Group 9's topic, which is on child welfare and protection from human trafficking. So now we move on to the SWOT analysis, and in this we're going to primarily discuss the strengths, weaknesses, opportunities, and threats with regards to the national program and the programs and their frameworks for child welfare. So the strengths are we have very robust legal frameworks in place, and there's also an increasing awareness via the media and medical schools and the promotion of this knowledge, as well as collaboration with other international organizations as well as local NGOs. However, the weaknesses are after exposure of the problem. There's nothing that's actually done to follow up on it and see that the victim in question is being supported through the entire way. We just highlight the point and then we forget about it. Someone else's problem at that point. And there's also the problem of insufficient funding, which is expected with a country as large as India. And as usual, there are gaps in enforcement. So some of the opportunities that can take place are we can educate the communities more so that there is engagement from their side, and therefore it's a stronger interlinking at the local level. There can also be a use of cross-border cooperation. So an issue that happens in a particular state or a city needn't be limited to that particular place. And there can be external help provided as well. And also we can advocate for general policy improvements. So however, some of the threats to this are social stigma, economic factors, and changing tactics of traffickers to avoid detection. So we move on to the next slide, the core message. So the main problem here are, as mentioned, poverty, weak law enforcement. There's no proper education, public education provided on the subject. And how this affects people is that children, in order to support their families, are forced to work as domestic servants in child labor and also engage in things like trafficking and begging. So as stated there, 12.6 million children engage in unsafe occupations, and according to the NHRC, 40,000 children are abducted each year, out of which 11,000 are never recovered. So there's no actual evidence for anyone being responsible because this is a multi-level problem. Every section responsible for these programs can all have their own issues, and it's our job to see where the exact problem lies and to fix the flaws in the system. So the solution would be a stricter implementation of acts. more stringent punishment given for these, and also to stay up to date on how traffickers are conducting their events currently, so that we can always stay one step ahead of them. And how this benefits people is by preventing trafficking and exploitation of women and children. There's also some to rehabilitate victims, and this improves the standard of living in the country. Um, So, what needs to change are the government and public have to get together, because there is a clear there is a clear gap between the government policies being formed and the public's understanding of it. And I think this has to do with the stigma behind child welfare and human trafficking. We like to pretend that things are going perfectly well when we know that they aren't. And there is this mindset of, if it's not my child or people I know, it's not my problem. And I think that's the main thing that has to be overcome. And we have to realize that every child is as important as our own. And then if we move on to the next slide for the policy frameworking, we'll see that there are four main programs with regards to child welfare. This is the Juvenile Justice Act, the Prohibition of Child Marriage Act, the POXO Act, as Vivek sir taught us, and Child Labor Prohibition Regulation Act. These are enforced via medical colleges and NGOs, and the information from these institutes and organizations are reported back to the government for further improvement. Additionally, medical colleges can also spread information, and this is picked up by mass media and social media, which can be relayed to the community for better engagement. And we'd like to thank AMSA and Girl Up Med for giving us the opportunity to present this presentation. And we are grateful for the support.
Okay, Gurnoor, can you just go back to the policy diagram, please, and just zoom in a bit. Okay, this is a good diagram, I feel. And just the font size and everything is on. Other than that, I don't think so. You finished it on time. Good work. So the last will be group 6, Shaishnu.
I'll share my screen now.
Yes, please.
Is it visible?
Loading. Your screen is not visible, Shaishnu.
Zoom quit unexpectedly. We'll start again.
Shall I
We'll-
do it for you in case?
No, there's some technical issue with Zoom happening.
Okay,
Give
I'll
me
wait
1
for
second.
30 seconds, yeah.
Yeah. Okay, I'll try again. Right, show, okay. Yes. Visible?
Yes, it's visible. Dipali, go ahead.
Yes. Good evening, everyone. Our topic is inclusion of comprehensive sexual education in medical schools. Um, we move to this SWOT analysis. Increased awareness of the importance of sexual um,
Is it not visible?
It is visible, but I think the slides are moving a little slowly.
Chaitanya, could you do it? For some
Yeah.
reason, when I'm screen sharing, my Zoom is crashing.
Okay, I'll do it. Okay, Dipali, are you ready?
Yeah. Uh, shall I start from the beginning?
I'll restart the timer. Go on.
Yeah. Good evening, everyone. Our topic is inclusion of comprehensive sexuality education in medical schools. Um, CSE is teaching young people about their bodies, relationship, and sexual health in a safe and supportive environment. Um, we'll move to the SWOT analysis. We start with strengths. Increase awareness of the importance of sexual education. More and more people are coming out and speaking about sexual education. We have seen the greater acceptance to LGBTQ community people. Support of social media and other online platform and organization have been coming forward and supporting the same. Policymakers are increasing and enacting supportive policies. Weaknesses, um, opposing. Firstly, on root level, opposing from parents. Then we have cultural taboos. For example, in India, we feel that the sexual education uh, um, um, impacts a negative on adolescents. Then we have lack of sexual education, religious opposition, and political opposition, lack of teacher training, funding, diversity in CSE programs, and emphasis on gender equality. Opportunities, integration, primary education, teacher training policies, and policy development, public disclosure, community engagement. Threats. Uh, Cultural resistance, political and religious influence, fear of loss, stigma and shame, and misinformation. Misinformation and misconception all about the content of sexual education may also contribute to resistance or opposition. Now moving to core message. Um, what is the problem? Inappropriate and incomplete sexual education in school and problems faced by the people because of this. How does it affect? It affects people by increasing sexually transmitted.
Is there a problem, Dipali?
More among adolescents. Hello, am I audible?
Yeah, is there a problem?
No.
Okay, okay, continue.
Yeah, more common among adolescents and children of our country, as sexual education is not taken seriously. Outline an example. There are various examples to it. Human examples are multiple. We have multiple cases of unwanted pregnancies in young adults, and a lot of youth showing up with STIs in clinic, issuing regarding and issues regarding sexual health. Who's responsible? So from the top level, government officials, parents, society as a whole, because of their taboos regarding sexual interactions, sexual health, and diseases. And what is the solution? Solution is a plan and policy framework design, and something more so based on the same, to bring a change and fulfill the objectives and aim. Benefit. How does it benefit people? Basically, this will benefit the next generation, young adults, and future population of parents, getting them rid of the taboos related to sexual activity, which will decrease the incidence of prevalence, STIs, unwanted pregnancy, and other psychiatric issues related to them. Evidence is what is the evidence of the solution? Evidence is based on the research showing that the data in developed countries with appropriate CSEs with modified and improved pattern of teaching and peer-based education have always been given the better outcomes, decreased unwanted pregnancies and sexual diseases. Um, who and what needs to be changed? The society as a whole, parents and their mentality needs to be changed. After the approach of school teacher and their resistance, bringing the change required for sexual education to bring the benefits needed for the same. What action? Um, what action needs to be taken by whom and whom? The action needs to be taken in a holistic and multidimensional way by multiple groups working together. The parent and society changing their mentality, school bringing various mentors and mentorship programs, implementing sexual education as per needs of different individual and students. This will be based on a framework designed by an appropriate group of individual, and it should be implemented with strictness and regular, and it should be modified at regular interval. And most importantly, it needs to be monitored. Now, moving on to policy framework,
Dipali,
we
I'll have to
have
stop you. The time is over 6 minutes. Okay.
yeah. Moving on to policy free. Okay.
Yeah, Dipali, the time is up.
All right.
Okay, so these were really good presentations. Like we did not expect so much. All the presentations are done, and I have selected top 3 presenters as well. This is totally based on your teamwork because I have been moderating and I've been keeping an eye on what is going on in your groups. So it is that into consideration, your flowcharts or pointers and how long you've taken to speak everything. And if you all really understand what you all have written, I have gone through all the 10 PPTs as well, how much ever was available at before 5 o'clock. So the first would be group 2 from Amisha. The reason for this is that there was a clear understanding and also it was within 5 minutes and 30 seconds. The next one is who's second is group 9, Gurnur. The only problem I felt was a small font size, and that is okay. I think you can actually just let it go 5 minutes. And the flowchart was really good. I think Pranav really explained it well. And the third and the final one is group 10 by Sanika. You'll the There was a lot of discussion in the group that I really liked, and I also personally interacted on the group. And it was a new topic for me as well because conflict zones are very common since the Ukraine and the Israel Gaza war and everything. And the only thing I would say is you all need a little bit more consolidation, but then I forgive you for that because the topic is really, really very broad. So these are the top 3 best presentations. And as I've made a note, you all will receive the certificates as well. Allow me to share today's feedback form to you guys, and then we can wrap this up for today. This was a really good workshop session. Like just 2 days, and I know the time is very less. This should be something on ground or something of a 1 week or 2 week process. But I hope everybody learned something. And please make sure that you fill the feedback form. That's the only way you'll be receiving the certificates. And everything I've been keeping an eye on, I know who has been actively involved, who has not been. So it will be accordingly. Don't forget to give your feedback, and we look forward to your participations in many more AMSA India opportunities. This is the AMSA membership form if anybody is here who is not an AMSA India member. The fees currently is 850 rupees. It's a lifetime membership and you do not have to pay every year. It's a one-time payment. So great to see you all engage and looking forward to seeing you all participate more in the tenure we still have left. So we have amazing opportunities coming up post the exam season and also during the exam season. So do engage in them. Thank you, guys.